The nursing process isn't a straight line. It's actually a dynamic, continuous cycle, especially in psychiatric mental health nursing, where the therapeutic relationship and communication aren't just tools, but the very foundation of care.
Really? I always thought of it as a step-by-step checklist. So it's more fluid than that?
Exactly. And that fluidity matters a lot because it reshapes how we approach patient care and clinical decision-making. In complex mental health settings, it's not about ticking boxes, but about an ongoing, evolving partnership with the patient.
That makes sense. So understanding it this way actually impacts patient outcomes?
Definitely. By the end of this, you'll see the nursing process as a living framework that blends art and science, culture and evidence, and above all, human connection.
I like that. Human connection at the core. So let's unpack this. The nursing process in psychiatric mental health nursing has 6 steps, right? Assessment, nursing diagnosis, outcome identification, planning, implementation, and evaluation.
Yes, but the key is that it's not linear. It's cyclical and ongoing. Each step informs and reshapes the others continuously. That's crucial because mental health conditions fluctuate, and the therapeutic relationship evolves over time.
So the relationship itself is central to the process?
Absolutely. Therapeutic nurse-patient relationship and communication are foundational standards of practice. Without that relational core, the process risks becoming mechanical and ineffective.
And collaboration with the patient is embedded in every step?
Right. From transparent data gathering to mutually negotiated outcomes and shared evaluation of progress. It respects autonomy, culture, and developmental context.
That's a lot to keep in mind. Let's talk about assessment, since it's the cornerstone. It's holistic and complex, covering physical, psychological, social, cultural, spiritual, and developmental dimensions.
Exactly. Nurses integrate data from multiple sources. The patient primarily, but also family, friends, medical records, and the interprofessional team. This is especially important when patients can't communicate fully due to psychosis, agitation, or cognitive impairment.
So assessment isn't a one-time thing.
No, it begins at first contact and continues throughout care, adapting as the patient's condition changes. For example, a patient admitted with active suicidal ideation may later have diminished ideation but persistent negative self-evaluation, requiring a shift in focus.
That's a good point. The mental status examination, or MSE, is fundamental here, right?
Yes, the MSE is like the physical exam in medicine, but for mental health. It evaluates cognitive, affective, and behavioral functioning in real time, and is often repeated frequently in acute settings.
What domains does the MSE cover?
Appearance, behavior, speech, mood and affect, thought content and process, perception, cognition, insight, judgment, and ideas of self-harm or harm to others. Each domain provides objective and subjective data critical for diagnosis and care planning.
It sounds like a complex, nuanced tool.
It is. And it's not just data collection, it's also a relationship-building opportunity. The timing, setting, and approach to the MSE are crucial for success.
What about the psychosocial assessment? How does that fit in?
It complements the MSE by exploring history, social supports, coping mechanisms, substance use, trauma history, cultural background, and spiritual beliefs. This comprehensive view informs individualized care and recovery-oriented planning.
Trauma-informed care is emphasized a lot these days. How does it apply here?
It's essential. Trauma-informed care principles emphasize safety, choice, collaboration, and empowerment to avoid re-traumatization and build trust. Patients often arrive with complex trauma histories, so this approach is critical.
And cultural competence?
Vital. Nurses must avoid stereotypes, use skilled interpreters rather than ad hoc translators, and engage in culturally safe practices. Understanding the patient's cultural context can prevent misdiagnoses and inappropriate interventions.
Developmental considerations vary widely too, right? Children, adolescents, older adults all have different needs.
Exactly. Children may regress or express distress through play. Adolescents require confidentiality assurances and sensitive inquiry, like the HEADSSS interview technique. Older adults may have sensory or cognitive impairments requiring accommodation and careful interpretation of symptoms.
The integration of physical health assessment is interesting too. Many medical conditions mimic or exacerbate psychiatric symptoms.
Yes, for example, hypothyroidism can present as depression, neurological disorders can cause psychosis. So lab tests and medical history are essential to rule out or address these factors.
Moving on to nursing diagnosis. This is where nurses make clinical judgments about the patient's responses and needs.
Correct. Nursing diagnoses have three components: the problem or unmet need, the etiology or probable cause linked with related to, and supporting data or signs and symptoms linked with as evidenced by.
So an example would be something like hopelessness related to multiple losses, as evidenced by lack of motivation to care for self.
Exactly. Nursing diagnoses focus on what nurses can address through interventions, distinguishing them from medical diagnoses. Well-formulated diagnoses improve communication within the care team and guide targeted interventions.
Then outcomes identification is about setting measurable patient-centered goals?
Yes, outcomes reflect desired changes framed as attainable, measurable, and time-bound goals. They must respect the patient's culture, values, and personal goals to ensure relevance and motivation.
Using both long-term and short-term goals helps structure progress?
Right. For example, for a suicidal patient, a long-term goal might be remaining free from injury throughout hospitalization, while short-term goals could include understanding suicide precautions and signing a no-suicide contract within 24 hours.
The nursing outcomes classification offers a standardized taxonomy, but individualization is key?
Absolutely. Standardized tools are helpful, but goals must be tailored to the individual patient.
Planning nursing care involves selecting interventions that are safe, compatible, realistic, and evidence-informed?
Yes, and evidence-informed practice integrates empirical research, clinical judgment, and patient preferences. Not all interventions have robust empirical backing, especially in areas like spiritual care, but clinical judgment and patient values fill those gaps.
Planning also incorporates recovery principles, like harm reduction, participation, and choice?
Exactly. It's about walking alongside the patient, rather than imposing care.
The nursing interventions classification provides a research-based list, but must be adapted?
Yes, for example, for risk for suicide related to despair with recent attempts, interventions include suicide precautions and close observation. For risk for suicide related to loss and loneliness, interventions focus on social support and community resources.
Implementation is grounded in the therapeutic nurse-patient relationship?
Correct. Basic level interventions include coordination of care, health teaching tailored to patient needs, milieu therapy to manage the therapeutic environment, and pharmacological therapies including medication, education, and monitoring.
Advanced practice interventions require specialized training?
Yes, such as psychotherapy, family interventions, group therapy, and consultation roles. Nurses must practice within their scope, with new graduates supported by experienced clinicians.
Evaluation is often neglected but essential?
Unfortunately, yes. Evaluation is a systematic, ongoing process assessing the patient's response to interventions and progress toward outcomes. It requires clear criteria and supporting data, including patient self-report and clinical observations.
Patient input is critical here?
Absolutely. Asking questions like, "How do you see things now?" or "What changes have you noticed?" fosters engagement and informs next steps.
Evaluation may lead to revising diagnoses, adjusting goals, or changing interventions?
Exactly. Without evaluation, care risks stagnation or ineffectiveness.
Documentation is sometimes called the seventh step of the nursing process?
Yes, and it's a legal document that must be accurate, timely, and comprehensive. It serves multiple purposes: communication among providers, continuity of care, legal accountability, quality assurance, and research.
What must documentation include?
Patient condition and changes, informed consents, medication administration and reactions, safety concerns and incidents, patient statements verbatim when appropriate.
Nurses must chart facts, not opinions or derogatory remarks?
Correct. Errors must be corrected transparently without erasing records. Confidentiality and privacy laws vary provincially, but generally require patient consent for sharing information, with exceptions for safety concerns.
Good documentation protects both patient and nurse and supports high-quality care.
Exactly. It's foundational.
I'm thinking about the story of the nurse helping a family understand schizophrenia. It really highlights the power of therapeutic communication and patient-centered care.
Yes, focusing on meaningful patient behaviors, like attending Sunday supper, rather than just medication adherence. It's a great example of meeting patients where they are.
The HEADSSS interview technique for adolescents is another practical tool, emphasizing confidentiality and sensitivity.
Right, it's a structured, non-judgmental way to assess psychosocial risk factors.
The MSE is not just a data collection tool, but a relationship-building opportunity.
Exactly. It requires skillful timing, setting, and approach.
Cultural and spiritual assessments are integral to holistic care, recognizing the profound impact of beliefs and practices on mental health and recovery.
And trauma-informed care principles are essential to avoid re-traumatization and empower patients, especially those with complex trauma histories.
The case of Martin Redbird really illustrates the intersection of physical illness, psychiatric illness, cultural context, and the need for culturally sensitive, holistic nursing care.
Yes, it's a powerful reminder that nursing care must be comprehensive and culturally competent.
So, to wrap up, the nursing process in psychiatric mental health nursing is a sophisticated, nuanced, and deeply human practice.
It demands clinical expertise, cultural humility, ethical rigor, and above all, a commitment to walking alongside patients on their recovery journeys.
Embracing the nursing process as a continuous, collaborative, and relational framework transforms care from a series of tasks into a meaningful, healing partnership.
Exactly. That's the heart of psychiatric mental health nursing.